So I guess in terms of options, so we classify contraception into short acting and long acting. So your short acting methods will be things like pills, the vaginal ring, the patch. And in terms of pills, you have the progesterone only one, which is single hormone, and then you've got your combined one, which is estrogen and progestogen. And then you have obviously condoms, there's male and female. There's things like diaphragm and caps, which are very old school, but are still there, and there are people who do use them. And then there's the long-acting methods, which can be things like your implant, your coils. So there's the hormonal coil and the non-hormonal one. And then you have the injectable methods. So there's also two types. There's one that you self-inject, and then there's one that is injected by the clinician.
I'm Shreya Parekh, and you're listening to Empower Her, the podcast for busy women aged 35 and beyond. If you're feeling stuck and unfulfilled with your health and wealth, get ready to be empowered to take action. My guests and I will be providing you with knowledge, resources, and ideas to help you broaden your perspectives, learn more about yourself, and define your path to live your absolute best life. Be sure to hit that follow button to stay tuned with Empower Her and check out the valuable free resources available on the website to support your journey. Sexual and reproductive health isn't talked about often enough as it should be, even though it's an extremely important part of women's health, and the responsibility usually falls on women to sort it out, especially when it comes to contraception and reproductive health in general. Join me today with Simphiwe Sesane, a contraception and sexual health nurse consultant. She's also the founder and CEO of Black Nurses and Midwives UK, with a passion for women's health. We'll delve into the topics of sexual and reproductive health and discuss how contraception and menopause fit into all of this. Simphewe prides herself on the ability to empower women with choice, leading to transformation and the protection of women. Simphewe, welcome to the Empower Her podcast. It's great to have you on. I'm excited to have this conversation because I think it's a topic that isn't really discussed that often, especially with women, and it kind of goes to the wayside, I feel. It's definitely something that I don't really think about either. Please, could you introduce yourself and talk a little bit about your journey from what you were doing and to what you're doing now? That would be great. Thank you so much.
Oh, thank you so much for having me on. It's lovely to be here. So I am Simphiwe Sesane. I'm happy to be called Sim. I am a contraception and sexual health nurse consultant. So I guess my journey into sexual health, so I started as a newly qualified Band 5 many moons ago, so 2012. When I qualified as a nurse, I sort of knew imminently that I didn't really want to work in acute care. I wanted to work in something that's sort of clinic-based. So that's when I sort of started my journey in sexual health. So I started sort of as a Band 5, testing, treating, seeing sort of people who attend sexual health. And then I sort of progressed my way up into the different roles. And now I sort of specialize in women's health. So I work for an abortion provider, and I lead on the contraception for my organization. So I do a lot of work around sort of promoting contraception, promoting good discussions, debunking myths around contraception, teaching health professionals around various methods, but also inserting coils and implants. And I guess my other hat in my advocacy role, I love sort of debunking myths around sexual and reproductive health. So spend a lot of time sort of delivering talks, going to different events, and just, talking about sexual and reproductive health, contraception, abortion care, and why it's important.
Yeah. And, there are a lot of myths, in general with women's health as well. And people assume lots of things about women's health. And I mean, I've discovered so much that I thought was true, and it absolutely isn't true. So, talking about sexual and reproductive health, can you talk a little bit about what that actually involves? Because, for me, when someone says sexual and reproductive health, I'm thinking like sex and having babies. But I'm sure there's more to it than that. So could you
definitely
explain a little bit about more what that actually means?
Yeah, no, and that is definitely part of sexual and reproductive health. But I guess Key thing, another thing is people talk about sort of sexually transmitted infections. So it's not merely the absence of an STI or sexually transmitted infections. It's all about sort of your sexual and well-being, consensual sex, not free from exploitation. There is obviously reproduction element. There's abortion. There's pregnancy. There's there's so much more that sexual health and sort of entails. And I think the key thing is thinking about it as sort of it's part of your normal care and something that we should be talking about sort of openly. And I think that's one of the key things that doesn't sort of happen.
Yeah, definitely. And I feel like, with sexual and reproductive health, it generally tends to be a woman's problem and a woman's problem to solve. And it really isn't, obviously. Could you talk a bit more about that, and how can we get other people involved in the conversation as well when it comes to sexual and reproductive health, because it usually falls on the woman, I feel.
It does. It certainly does. And I think key thing, I think it's education. We need education at different levels. Even recently, there's been changes around sexual health education and, limiting or, putting a ban at a certain age. So ensuring that it starts from say 13. But from data, we know that, children are accessing porn a lot younger, which means that essentially at 13, it may be too late. And I think, the education element needs to happen at all levels. It's not just a woman's problem, it's everybody's problem. So there definitely is a lack of education, a lack of research, a lack of knowledge around sort of the different areas of sexual health and what it encompasses. And you're definitely right. I think it's been made as if it's a woman's problem, but I think that needs to change. And there's a lot of us who are advocating for change within women's health. And ensuring that it's everybody's problem. So like menopause, it's not just the women who are going through it. It impacts so much, your work, your children, your partner. So I think it's so important that we're really opening up these conversations and just normalizing those discussions.
Yeah, absolutely. And it is great, actually. We're working towards something great, which is brilliant. And we're shouting out louder, not shouting, but we're we're letting it be known that women's health is not the same as men's health. It is absolutely not. And we need everyone to be a part of this conversation.
Definitely.
Men, women, children, grandparents, elderly,
everybody.
Because otherwise we're not going to be able to understand each other. And that's not to say women should also be understanding men's health as well. It's a two-way thing, right?
It totally is.
Yeah. It's not just one way, everyone should just learn about women's health. It's a two-way thing, but we all need to learn about each other's health issues. And they're very, very different because our physiology is very different.
Super, super different. And I think it's just remembering as well, in terms of our NHS, it's built on white men, essentially, able-bodied men. So I think that needs to change, that narrative needs to change. But unfortunately, some of it is so historical and is so embedded. And it's going to take a lot of work for that change to absolutely occur. And like you're saying, yes, we're going to shout, or not quite shout, but definitely keep banging those doors to ensure that change is, benefiting women.
Yeah, absolutely. In terms of sexual health, then, I want to kind of talk specifically on that. What are the things that women should be looking out for in terms of, protecting themselves, not just contraception, but just, sexual health diseases and things like that? What should they be looking out for? What diseases are out there? What are the signs, symptoms? I know you probably can't talk about every single disease.
No.
Maybe the common things that women should be looking out for. And then obviously, these things happen at different stages of women's lives as well, potentially, the key, puberty and then menopause, going through perimenopause and then having the menopause that one day in your life, and then post-menopause as well. What are the kind of differences with that as well?
So I just want to start off by saying that, nobody knows your body better than you. So if anything is new, anything has changed, always go and see a health professional and just discuss your concerns. And no question or concern is a silly concern. So any concerns that you have, always ensure that you go and discuss it with somebody who's qualified. I think at the moment we're going through a, you know, a turmoil because people have a lack of trust, especially Black and ethnic minority women have a lack of trust in the health system. But I just want to just emphasize the importance of going and seeking the right help and support. And if it means, asking a second, a third, a fourth opinion, hopefully it won't get to that. But yeah, you know your body better than you. But I guess in terms of drilling down to sort of signs and symptoms, so if there's ever a change in bleeding, that can be alarming. So if you generally have sort of one period a month, and that's how it's been since you've started your period, and suddenly you're having bleeding in between periods, or you're having bleeding after sex, then that can be sort of a red flag. It doesn't necessarily mean that it's something sinister, because I think sometimes when you read on the internet, it's like you've got cancer, but it's not necessarily that, but it's something that does need checking. If you're having any discharge changes, so if it's suddenly cloudy, or it's got a smell, or it's just it's increased, then obviously that would be something as well that would, insinuate that you need to get checked as well. If there's any new lumps or bumps within the vulva or in different areas of the body that you've noticed, then that's also something to check. So in terms of sexually transmitted infections like gonorrhea, chlamydia, which are the more common ones, those definitely cause things like bleeding or vaginal discharge. For some women as well, they can experience abdominal pain. Pain when urinating could be key sort of indicators as well. Lumps or bumps can be things like warts, which are caused by the human papillomavirus. There's over 100 different types of human papillomavirus, but there's 2 key strains that cause warts, which can appear on the vulva and different areas in the sort of anal margin area. And they're generally non-painless, but can be itchy for some women, or can be something called molluscum, which is also another sort of infection which can appear and causes non-painful lumps within sort of the genitalia area. And then there's another sexually transmitted infection called HSV, or herpes simplex virus. So most people know it as the cord sore virus, which can appear on the sort of mouth, but that can appear in the genitalia area. And those ones tend to be little ulcers that appear, can be one or multiple, and they tend to be itchy and sore. So people usually sort of notice those ones more than warts. I'd say with warts and molluscum, sometimes it can take a bit of time for people to notice those infections specifically. Any changes, like I said earlier, always come in. So your sexual health clinic is probably a better place to go, just because they see these all the time. GPs can be great as well. Obviously, seeing a women's health specialist may be sort of better. But yeah, definitely seeking the right sort of help and support. And I'd say, sexual health, it's their bread and butter. So sometimes it is a lot better to sort of go to them. So those would be your main sexually transmitted infections. And then there's obviously your bloodborne infections like HIV, syphilis, and hepatitis. And those ones don't necessarily cause symptoms, especially early on. So sometimes people actually don't want to screen for those tests. They're like, I'm low risk, especially if they're in a heterosexual couple. They may find just normalize kind of, no, I'm not very high risk. I think especially with things like HIV, it's been almost made as if it's a gay disease, but actually there are people who are not gay who do have HIV. So I think it's important that we normalize testing for everything. So if you're going in for a sexual health test, doing your gonorrhea and chlamydia, but your HIV and syphilis, and if there's hepatitis risk as well, then obviously doing that as well.
Yeah, you're absolutely right. Actually, with the HIV, it is, so many people assume it's a gay disease, and it's not.
It's not.
There is that perception there, which I'm glad you've highlighted.
Sure. Definitely, I think that's kind of a stigma as well, and around HIV testing, that still definitely exists. So I think we need to normalize testing for everything. I guess in terms of life course, in terms of a woman, obviously sexually transmitted infections like gonorrhea and chlamydia, we used to think is a younger person's STI essentially. But actually, in terms of the data recently, we found that there's increased STI rates in women over the age of 35. So it's important that we also get tested. So sometimes there is potentially, let's say, a relationship breakdown, and they're dating again, and sometimes women forget about things like STIs and contraception. So there's definitely a change in the data that we're seeing sort of recently in terms of sexually transmitted infections and just contraception in general. So there's definitely a move in terms of contraception. So there's different methods. Some have hormones, some don't. But we're seeing a lot more women wanting non-hormonal methods. So not wanting, hormones inside their body, or saying they're toxic, or other beliefs around sort of hormones. And there's definitely side effects. I don't want to say there isn't side effects, but I think it's finding the right contraception for you. And if you are experiencing side effects, going back and having a review and discussing what your concerns are with that particular method. Don't just stop, because obviously we don't want a risk of pregnancy.
Yeah, absolutely. Just going back to the point you made about, obviously women should know, well, they generally know if there's something that's not right. You know what's normal, and you know what's not normal, and you should make that normal practice, like as in, this is me normal, and this is something that's come up and it doesn't feel normal. But in terms of checking your vulva and for lumps and bumps and things, how that's something, I don't know. I mean, I'll admit I don't really do that, but how often should we women be doing that and checking down there? Because it seems something, women know about checking their breasts, most women do, and maybe they check that regularly, but down there it's kind of like,
That's a bit,
it's a bit kind of, how do you check it, and how often should you be checking?
No, that's such a good point. And definitely, I think even with the breast checking, there's still women not doing that. I think the key thing is just fit it into a routine. If you're checking your breast, you might as well check your whole body, because you can have lumps appear in different places of your skin as well, which may need to get checked. So I think normalizing it maybe once a month, really getting a mirror, checking, having a look, and being familiar with what's normal. Because I guess another thing is that people don't actually know what's normal for them. Sometimes we're even using incorrect terminology, describing the vulva, but calling it the vagina, and interchangeably. So I think it's knowing what's your normal, having a good look around. From the pubis all the way around the vulva, looking in the anal margin, and just looking at the skin integrity, the color, the shape, all of that is so important. And doing it once a month is good, because if there's any change, you'd rather detect it early rather than discovering it a lot later. And sometimes it might be just little cysts, which can appear on the skin, which are not sinisters. But if it is something more serious, then the earlier it's found, the better.
Yeah. And in terms of menopause, now I know women experience different symptoms around that time, and so how can you differentiate between, is this like, is my discharge, for example, extra discharge or whatever, or the change in my discharge linked to my perimenopause symptoms, or is it something else? How can you know that?
And you don't. You really don't. So like I said, any change, get it checked. There's no harm in sort of going to your GP or your sexual health clinic and having a check. So if there is any deviation in discharge, then I think it's important to check that. In the perimenopause phase as well, the bleeding we know can be irregular, infrequent, or can be all over the place. Key thing is that if you are having bleeding, obviously we like to see you and check things like smear. Are you up to date with your smear test? If you're still having bleeding, we may examine you just to check if there's anything else like polyps, which may be causing bleeding. We want to do a scan sometimes just to see if there's anything else in the endometrium, just to check the lining of the uterus, check the ovaries, see what's potentially causing this bleeding. We may do swabs as well, not only for sexually transmitted infections, but testing bacterial infections as well. And if you are having bleeding, especially if you've now gone post perimenopause but are menopause and you've not had a period for greater than 12 months, you start having bleeding, then that can be also a red flag, and we definitely want to see you sort of a lot sooner. Obviously, if you're using hormone replacement therapy, that can also change people's bleeding. But I think the key thing is that at any stages, if there is any deviation, it's better to be checked rather than just to sit at home and just, hope that it resolves. You're not wasting our time. We need to see you. And if it does mean asking for a second opinion, so be it. But please do go in and get any changes checked.
Mm-hmm. When you talk about going to the sexual health centres?
Yeah.
So just so that the audience knows, are they kind of available for anyone to just, is it kind of, do you just drop in to your local one, wherever that may be? Or do you have to make an appointment, or do you have to go through a GP to be referred there? How does that work?
Yeah. So I guess there's been a massive change. That COVID definitely impacted health services and how we book into sexual health services. So before, we used to have a book system and a walk-in system. So you walk in and you can wait. Whereas nowadays, it tends to be more booked appointments unless it's an emergency. Like I said before, COVID has definitely impacted how you access services. So before, you used to have booked appointments, but also the possibility of walking in and just waiting. And obviously the wait can be, anything between an hour to even longer than that. Whereas now it tends to be more booked appointments. There are services which still do offer walk-in, but I'd say if you are walking in, going in earlier is always better, because then if they meet their numbers for walk-ins, then they are unable to see you until the next day, and it'd be the same process unless you're able to book an appointment.
Mm-hmm.
You don't need a GP referral, apologies. So no referral required from like GP or a different practitioner, so you can self-refer and self-present.
Okay. And under what kind of circumstances would you go to one of the centres? Could it be just symptoms? Just, I don't feel right in my body with, these symptoms. Not, I don't mean like, cold and coughs and things, but to do with sexual and reproductive health generally.
Oh, for sure. You don't have to have symptoms. One, let's just normalise testing just overall. So even if you are in a regular relationship, you've got one sexual partner, been together for a long time, we still advise testing at least once a year is good practice. So it doesn't have to be symptoms. So obviously with that, you wouldn't necessarily have an urgent appointment, so you can book an appointment or request a home test kit. So nowadays there are home testing kits where you request it and it's posted to your house. You do a little finger prick test, which tests for HIV and syphilis. You do a self swab yourself and you put it in this box, post it, and they literally send you results within a week. So there is that option as well, if you're having a test and you don't have any symptoms. Whereas if you do have symptoms, then obviously, yes, you can definitely present. It sort of, I guess it depends on the actual service. But yeah, if you've got symptoms, definitely walking in is an option, but it just depends on that particular service. So sometimes if you check on their website, it will tell you whether there's booked appointments, and some you can actually book an appointment straight away on their website. But it will tell you around the different, like what is the accessibility for that particular service.
Yeah. And I'm assuming, either your GP would know where your local one is, or you can simply just do a Google search, like where's my local sexual health clinic, and find that and go online and just hopefully just book in. And they, that's
definitely. Google's your friend. Well, with like searching for services, not for symptoms. Like I feel like for symptoms, let's stick with the professionals, because like anything with Google, it can tell you that you've got cancer or all sorts of stuff. So we need to use credible sources. So if you are wanting to like look at symptoms, Google's not your friend for that. But if you look at like NHS choices, NHS, website, looking at, reputable sources, then that is much better. But your GP will know where your local services are. I think places like London, we're very fortunate because you actually do have multiple sexual health services. So you can go to anyone. So you're not confined to your local one. So you could go across the river to go to a different place if they have availability a lot sooner. If you're outside of London, it becomes a little bit trickier. Sometimes people have to travel longer distances to access sexual health because it might be in the next town, for instance, and that's the only sexual health service. So definitely have a look and see what's available in your local area. And definitely have a look, because you can also go to them for contraception. It doesn't purely have to be the testing element. Or if you've got side effects from a contraception and you want to discuss changing, that they can do that too.
Yeah. So moving swiftly on to the contraception, which is what I really want to talk about now, because there's a lot of contraception out there. And again, I feel like it becomes a woman's problem, figuring out contraception, what they should be doing, what they shouldn't be doing. And then also the myths around the side effects, or not just the side effects, like there's stories out there that if you put this into your body, it can cause this, that, and the other. So firstly, could you kind of talk about what contraception is on offer? Is there any male contraception on offer? I'm not sure, actually. I don't know. I'm hoping there would be by now, but probably maybe not. And I guess, it stems down to, it's a joint conversation. It's not just, oh, I have to find it myself. I have to think about it myself. It's a joint conversation that perhaps you should take your partner to discuss what you should both be doing. So what options are there out there, and what are the myths associated with those options as well?
So I guess in terms of options, so we classify contraception into short acting and long acting. So your short acting methods will be things like pills, the vaginal ring, the patch. And in terms of pills, you have the progesterone only one, which is single hormone, and then you've got your combined one, which is estrogen and progestogen. And then you have obviously condoms. There's male and female. There's things like diaphragm and caps, which are very old school, but are still there, and there are people who do use them. And then there's the long-acting methods, which can be things like your implant, your coils. So there's the hormonal coil and the non-hormonal one. And then you have the injectable methods. So there's also two types. There's one that you self-inject, and then there's one that is injected by the clinician. And then obviously there's other sort of methods which exist, like sort of withdrawal. Obviously, we don't promote that because there's high risk of pregnancy. And then there's non-vaginal, non-penetrative sex, which is still classed as a form of contraception as well. I guess the key thing with anything that contains hormone, potentially it will cause side effects, especially when you first start. Common side effects tend to be things like skin, mood changes, breast tenderness can be sort of usual things that people notice, change in bleeding for some people as well. I think the key thing is that you do need to give it a bit of time for it to settle down. So we're not saying stay on it. I think sometimes people feel like we're just dismissing sort of the side effects that they're having. But like anything that's new to your body just needs a bit of time to adjust. So we tend to say 6 weeks is sort of the time frame that is pertinent, whether this is going to improve or not improve. If you can ride it out until 3 months, then awesome. If it's really unbearable, then obviously go back to a clinician and speak about the side effects that you're having. I always talk about diarising. That's so important, like from starting, and what are the key things that you're experiencing? Is it getting worse? Is it improving? Have you noticed something different? Is always important as well. In terms of myths, there's obviously so many different myths. I guess the risks with any contraception, especially hormonal-based, like combined methods, there is a slight risk of blood clots. That risk is very, very low. So things like obesity, so with all the risks I'm talking about, yes, they exist, but obesity, alcohol, smoking actually has more risks than the risk that we talk about. So the risk in contraception is very negligent, but I think sometimes when you see it on media and the pill has had a bad rep for so long, it's actually negligent in terms of the risk. So there is definitely a risk of blood clots, especially with the combined method. And if you do have a family history of blood clots, then especially if it's a first degree relative below the age of 45, then the combined method might not be the best one. any hormonal methods, we know there is a slightly increased risk of breast cancer as well. And again, it's very negligent in comparison to those other risk factors that I explored as well. And then there's obviously concerns around fertility when it comes to contraception. So it's all artificial. While you're taking it, yes, it prevents pregnancy, but once you stop, then that generally fertility returns to normal. The only one where it can be delayed is the injectable methods. It can take up to a year for fertility to return to normal.
Oh, wow. Okay. I wasn't aware of that. Yeah. I mean, look, you know, there are lots of, like you said, Google can sometimes, and the media in general, not just Google, you know, social media, the TV, wherever you get certain information from, it's kind of scaremongering, and people get glued to fear, you know.
Yes.
They you know, for whatever reason, I'm not going to go into the psychology of it because I have no idea, but, you know, people, when they see fit, you know, when something's like, this causes potentially cancer, or this causes this, it becomes like, oh my God, people just want to watch it and absorb it and then take that in. And I know, you know, the pill and certain other things, when you're putting this kind of stuff into your body that's not, you know, natural, that it's kind of artificially made or whatever, people think it can later on maybe cause some cancers, or it can prevent you from having children, or whatever that might be. But I guess, like you said, some of these things are myths. There are risks involved in taking a lot of these contraceptions. What do you say to women that, you know, they are worried about putting, you know, this kind of stuff into their body, and don't want to? What are the choices for them?
Yeah, so actually there are choices for them. So there's the copper coil. So that doesn't consist of any hormones, but it can change your periods, may make your periods heavier and more prolonged. There's also natural cycles. So natural cycles are around, you know, tracking your cycle. So you have to have a regular cycle. If you have an irregular cycle, or your cycle changes, then unfortunately natural cycles is not the best one for you. So you basically track your cycle, because then you can kind of estimate where your ovulation is, so you know when to avoid the high risk zones. It does also require you measuring your temperature and things like that, and, you know, checking your mucus to see what sort of discharge are you having, or what sort of mucus, because then sticky mucus and things like that can suggest that, okay, you're closer to ovulation, and that's higher risk in terms of pregnancy. So there is a lot more work that's required in terms of natural cycle, but it can work very highly effective. But I think the problem is that the level of work that's required in terms of using it. Yeah. And then there's obviously non-penetrative sex. That's the method of contraception, which can obviously prevent pregnancy because you're not having penetration, but you could have, let's say, oral sex and other ways to be intimate with your partner as well. But unfortunately, it's very limited. You know, as much as we've made, you know, positive leaps and bounds in terms of contraception and options, but we still are very far. You know, if you think about it, we're still giving microgynon as the first pill, which was one of the first pills to ever be invented. That's still our first line contraception. Wow. In practice right now. You know, it's been around the longest. It has the most research and data, and actually it is the safest because we have the data for it. There is obviously a lot more newer ones, which also have body identical hormones. We don't know as much. So they've been around for less than 10 years. There's some that have been discovered in the last couple of years. They have positive experiences in terms of when people review the various methods, but we don't have the longevity that we have for things like microgynon. But we know they're better at, you know, bleeding control. Some people also report sort of the skin issues are not so prominent, and things like the mood seems to be a lot more positively reviewed on those particular methods, but we still don't know a lot about them.
Yeah. I mean, I think, you know, just generally, then we're kind of we're not progressing quickly enough with the research with women's, you know. Yeah, I mean, I can't believe we're still using microgynon. I mean, that's what I used a long time ago. And, you know, I mean, I don't think it personally agreed with me, but
Yeah.
I can't believe we're still talking about microgynon.
It's still our
like,
first line. Yeah, it
yeah,
definitely. I mean, we've moved on, but we're still there. So definitely more needs to change. And the problem is
yeah,
that when we have newer brands, like a bit like I spoke about the body identical ones, they are more expensive. So if you think about microgynon, which is sad to think that we're putting people just because something is cheaper, but unfortunately that's the
yeah.
society we live in currently. So microgynon, for instance, you can even source it for like £1, and these newer pills can be anything from like 30 pounds, so for
Oh,
three.
okay.
So it is a significant larger
Yeah,
amount, and imagine if you start on that particular method and actually it doesn't suit you, and you started on the most expensive. So there's obviously that's not fair on that
yeah.
particular woman, but unfortunately that's how the system is, and it's definitely disadvantaging women. But we also have the data in terms of microgynon that we don't have for these other pills that are newer. We just don't have the longevity.
So
Yeah.
what would you say, your kind of top 3 tips for women are, and I'm talking generally,
Hmm.
in terms of, women of all ages, the symptoms could be different at different points in their life.
Yeah.
But in terms of, ensuring that you really consider this area of, your health quite seriously,
Hmm.
just as serious as you may take other areas of your health. What would be your top 3 pieces of advice for women to make sure that they kind of incorporate this, and what they can do really if they think that there's something wrong?
Yeah, no, definitely. So I guess a bit like what you were saying. So your sexual health and well-being is just as important as your physical, your psychological health. So it's important that you normalize testing, you normalize accessing sexual health services, or wherever you go, if it's through your GP, but basically taking pride in your sexual health and well-being. So it's not only about the absence of disease, but it's also thinking about pleasure. you
Mm.
know are you having pleasure during sex? Is it painful? Have you seen somebody? Have you discussed those concerns around the key things? So there are obviously conditions that can cause pain, but sex should be pleasurable. If it's you're having pain, you're having bleeding, or you're having things that you're concerned around when you're having sex, then having those checked as well is important. Thinking about contraception, yes, you might not want to use actual active contraception that's hormonal, but also having those options, but discussing that with a clinician, but also your partner. If you do need contraception, then it's important that you guys have that open discussion about your long-term plans in terms of contraception. And obviously, if it is around pregnancy as well, I guess that sort of features into your conversation as well. And in terms of, I guess, when you're at a perimenopause stages as well, is not forgetting contraception, because sometimes I think when women are using HRT, they think that it will protect them in terms of conception as well. But yeah, don't forget your contraception. So your HRT is your HRT, unless you're using a Mirena, then that can use Bejewel, where it's contraception and your HRT component, but not forgetting to also use your contraception. But yeah, just taking pride in your sexual health and well-being, normalizing conversations, normalizing testing, normalizing talking about pleasure and sex, with your friends. We should be having pleasurable sex. It doesn't mean you're promiscuous. And I think there's often this negative connotation as women that we're not supposed to have pleasure.
Yeah.
It's a man's thing. And it's no, sex should be pleasurable. So if there is anything that's changing that pleasure element, then yeah, definitely seeing somebody to discuss. And maybe there is, something like vaginismus, which is a condition where there's spasming that occurs, and that's what's causing the pain. And there's a lot of work that can be done, to resolve that. So it's important that you talk about it. Don't be ashamed. Normalize it like everything else that you would go and say, I've got a lump that I've noticed in my breast, or something like that. So yeah, that would be, I guess it's not 3, but it's like a whole spiel.
Yeah, absolutely. And of
Yeah.
course, for, if anyone wants to find out more, they can follow you on your social channels, which I will put in the show notes, because you provide lots of information. Very, very, very clued up about sexual and reproductive health, that is for sure. The other thing, I want to highlight is thank you for kind of really pointing out that you can just go to your sexual health clinic every year or every 6 months, how often you kind of need to just get tested for all these things to know that you're fine. And then obviously if there's something, they will refer you, which is great. And that's something I didn't actually know. I thought always you have to go to your GP first and then, explain or say this, but this makes the process so much easier. And I'm hoping lots of women will now start, booking in and getting that check, because it's great that is offered. That's something I didn't know, to be fair. So thank you.
My absolute pleasure. And education is power. You can go there to actually discuss some concerns that you have around sex and well-being and sexuality and all the different aspects. So normalise tapping into that service, and it's there. It's there for everybody. It's not just for young people who are having sex. It's there for everybody.
Yeah, absolutely. Yeah, thank you.
Definitely.
Sim, thank you so much for being on the Empower Her podcast. It's been great to have you on. And like I said, please follow Sim. She has got a wealth of knowledge on her socials. So if you need any advice on that, go there. But thank you so much.
Thank you so much for having me.
Thanks for tuning in to Empower Her. I hope today's episode has left you feeling inspired and motivated to make a positive difference in your world. Please follow the podcast and share it with anyone who will find it helpful. Until next time, keep striving for positive change and greatness for all women.